Hi friends. So today's my topic is the diabetic-keto-acidosis, which is the very important complication of the diabetes mellitus, and it has acute presentation. Okay, so first of all, we will get some brief idea that it is more common in type 1 diabetes mellitus than type 2. It is the complication of the DM, and it is more common in type 1 than type 2. Why it is more common in type 1 than type 2? Because diabetic ketoacidosis is due to insulin deficiency. The main culprit here is insulin. Insulin is deficient in the body, so whole cycle will start and it will end in diabetic ketoacidosis. And we know that type 1 diabetes mellitus is insulin dependent diabetes mellitus. It is due to the insulin deficiency in the body rather than type 2, which is like due to insulin resistance, etc. But type 1 is purely due to insulin deficiency in the body. So it is more common in insulin deficient patient like type 1 diabetics, and some factors which will increase the demand of insulin in the body, like stress and some surgical intervention and some infection. Okay, secondary infection where DM1 diabetes mellitus 1 is already there. So this will increase the demand of insulin. These three will increase the demand of insulin, but body is suffering from insulin deficiency. So now the cycle of the diabetic ketoacidosis will start. Diabetic ketoacidosis is the result of that cycle. Now we will discuss this cycle. It is important. We will give it title of pathogenesis. Now what happened in diabetes patient? Assume that this is blood vessel, okay, and this is cell of the body. Now our blood is having glucose. Okay, this glucose will go into the cell. This is cell and this is blood vessel. Okay, this glucose will go into the cell and cell will utilize it for energy. But for transferring the glucose from blood vessel to the cell, we require insulin. Without insulin, this transfer can't occur. Okay, and here we are having insulin deficiency. So what will happen? The glucose will not come into this pathway will be cancelled, and glucose will not be there in the cell, and glucose will be in high amount in blood also. Okay, so cell is not having glucose at all. Cell is suffering from glucose deficiency, but in the blood vessel we are having excess amount of glucose. So here we are having kind of hyperglycemia, and in the cell we are having kind of hypoglycemia. Now this cell will give message to our CNS, our brain, that he is not getting sufficient amount of glucose to work. So what will brain do? Brain will start counter regulatory mechanism. Brain will secrete different hormone like GH and glucagon, cortisol, epinephrine. This all hormone will try to increase the glucose in the body. How will it work? It will cause, this hormone will cause two things. One, gluconeogenesis. Second, glycogenogenesis. glycolysis. Glycogen will be break down, glucose will be formed. Glycogenolysis and gluconeogenesis. So what will happen? So main area of this mechanism are two. First is the muscle and second is our fat adipose tissue. So first we will start with muscle. So in the muscle, what will happen? The glycogen will break down due to glycogenolysis. So what will happen? Glycogen will be converted into glucose 6-phosphate, and this glucose 6-phosphate will form lactic acid. Now this lactic acid will go in the blood vessel, and this lactic acid will go in the blood vessel, and from blood vessel, in the blood vessel we are already having glucose in high amount. Now from blood vessel, this lactic acid will enter into the liver. This is our liver. Okay, now this lactic acid will enter into the liver, and in the liver this lactic acid will be converted into glucose, because our mind is assuming that body is not having sufficient amount of glucose, and this glucose will enter in the blood circulation, where we are already having excess amount of glucose, which will increase the glucose concentration further. So in the muscle, what will happen? Glycogen, glucose 6-phosphate, then lactic acid will go into the blood vessel, and this is our liver. Okay, so this is liver, and liver will convert the lactic acid into the glucose will again enter in the blood vessel, and we will having more amount of glucose in the body, hyperglycemia, more amount of glucose in the blood, hyperglycemia. Now what will happen in the adipose tissue, fat? What will happen in the adipose tissue? So we know in the adipose tissue we are having triglycerides, and this triglyceride will convert into fatty acid, and this fatty acid will enter into our blood vessel. Okay, this fatty acid enter into blood vessel. Fatty acid will enter into blood vessel. Okay, now from blood vessel it will enter again into the liver. This is our liver. Fatty acid will enter into the liver, and from in the liver it will convert it into glucose, and this glucose will enter into the blood. So this is normally going, and this step is our main. This step is inhibited by insulin. This step is inhibited by insulin, but in our patient we are not having insulin, so this step will not be inhibited. So there will be more and more conversion of this, and there will be high amount of fatty acid. This high amount of fatty acid will enter into the blood. From blood, high amount of fatty acid enter into liver, and what will happen? High amount of glucose. But in our patient we are already having hyperglycemia, and further glucose will be added. So what will happen? Hyperglycemia will get worse. Okay, so these two mechanisms are important. Now our liver has some capacity to convert fatty acid into glucose. After that threshold is reached, this fatty acid after that threshold is reached this fatty acid will be converted into ketone, not in the glucose. Initially there will be high production rate of the glucose, but once the threshold is reached, it will converted into ketones. Okay, now ketone, there are three examples, like acetone is most common, and acetoacetate, beta hydroxy, butyrate, all these are there. This ketone is acidic in nature because it will give H plus ion. It will donate H plus ion. Now what happen, that this ketone will enter into the blood vessel, and it will give H plus ion, we know that. So H plus ion in the blood will be more. Okay, now this H plus ion will bind with SCO3 present in body and will form H2CO3, which will be result in H2O plus CO2. Now we have to learn 4 important symptoms or signs, you can say, of the diabetic ketoacidosis. First, 4 important signs of diabetes ketoacidosis. 4 important sign symptom. First, that ketone has a property of irritating or stimulating CTZ area of brain. So what will result? What will happen? Patient will be having vomiting and nausea. This is our first symptom. Patient will be having vomiting and nausea. Okay, now ketone has another important characteristic, that it will irritate the gastric mucosa. And it will result into the abdominal pain. So this is our second symptom due to the ketoacidosis. Okay, this is number 1, this is number 2. Now we are having excess amount of body water and excess amount of carbon dioxide. So due to the excess amount of carbon dioxide, what will happen? It will stimulate the respiratory centers. It will stimulate the respiratory centers and it will result in high respiratory rate and hyperventilation, and CO2 will be washed out. CO2 will wash out. Okay, CO2 in blood will be decreased. So all these three, what will result of this? There is a specific breathing which will be having feature of the hyperventilation, high respiratory rate, and it will have some smell like sweet fruity smell to breath. First, high respiratory rate, hyperventilation plus sweet fruity smell, and all these three together will give our third presentation, which is the sign, not a symptom. And what is this? It is a Kussmaul's breathing. So this is the most important sign of our diabetic ketoacidosis patient. Number 3 sign. Okay, now what is the number 4? Number 4 is simple. Body is having excess amount of water. Now this excess amount of water will go into the kidney. From kidney it will go into urine, of course, and patient will remove it and will suffer from features of the polyuria and dehydration kind of thing. This is our number 4 symptom. But symptom number 1, 2 and 3, symptom sign number 1, 2 and 3 are due to ketone specifically, because this is due to excess amount of water in the body. So this is presentation of our diabetic ketoacidosis patient. Now I will give you some brief idea of the normal physiology. That this is our blood vessel, this is our cell. We know that cell is rich in potassium, and in our patient we are having H plus ion in the blood. So our patient is having H plus ion in blood vessel. Now here there is low K plus potassium, and here there is low hydrogen ion. So according to rule of physiology, there will be exchange of the ion. Okay, and the potassium will go into blood vessel and H plus will go into the cell. So we are focusing on potassium. That potassium, if you want to go into from blood vessel, now potassium has entered into blood vessel. If potassium from blood vessel again try to go into the cell, in our patient these two steps will happen. That potassium will enter into the blood vessel and hydrogen ion will enter into the cell. But now our blood is having high amount of potassium, which is so dangerous that it can end into the arrhythmia. So our potassium will try to escape from the blood vessel and again try to go into the cell. But this was step number 1, step number 2. These two will happen in our patient, because these 3 steps require the insulin for action. Without insulin, the step number 3 can't be happen. So this step 3 will not happen in our patient. Now our patient will suffer from intravenous high K plus. So I will present the ideal case of the diabetic ketoacidosis to you. That 20-year male patient, which is the known case of type 1 diabetes mellitus, may be unknown. Like early presentation will be directly to diabetic ketoacidosis, may be present in the patient of the TM type 1. So patient will come with the clinical features of the fever. Fever may be due to the secondary infection. We have learned that fever infection can start the cycle of the diabetic ketoacidosis. The patient will may or may not will come with, I am giving ideal case, so it will come with fever and loose motion and vomiting and nausea and etc., with abdominal pain since morning and nausea, vomiting and dyspnea, difficulty in breathing, hyperventilation. So when you check the blood sugar, it will be like 500, 600, etc. So this is the presentation of the diabetic ketoacidosis. Now main part, how will you treat? Main part is our treatment part. So how will you treat the patient of diabetes mellitus? So treatment, which is important. So how will you treat? So first of all, 3 modalities are there. We will give IV fluid because patient will be suffering from dehydration. Okay, so we will give IV fluid and insulin and potassium, but these two will have to be given calculatively. We will give IV fluid. We will start the treatment with IV fluid first. So what will we give? IV fluid, insulin and potassium. Okay, so we will give normal saline, which is 0.9% at the rate of 50 to 20 ml per kg per hour for first 3 hours. After that, we will change the dose to 250 to 500 ml per hour till sugar comes below 200. Okay, so this is ideal, but maybe patient will be having sodium level high, because whenever there is decrease in glucose, there will be increase in sodium. Okay, so we will check the sodium level. Of course, we have to check potassium level, so we will check sodium potassium level along with, and if we find that the sodium level is high than the normal, then we will convert this NS to half NS. So we will convert this NS to half NS. So we can do this step, half NS, when sodium level are high, when we are having high amount of sodium. Okay, so this is normal IV fluid. Now what about the insulin? So in the insulin, we will give regular insulin. But before insulin, what will we do? We will check potassium level before insulin. We will check potassium level. So first step is this, second step is this, and insulin is our third step. So why we want potassium level? Because if potassium level is low and you are giving insulin, because potassium level, why potassium level will be low? Because here we suggested that intravenous potassium will be high. Intravenous potassium, here plus mark, intravenous potassium will be high in the diabetes patient. So why it can be low? Because patient will be coming with nausea, vomiting. Patient will be coming with nausea, vomiting. So he can lose electrolytes in that. Patient may be having diarrhea also, and patient is dehydrated also. So patient can lose electrolyte in that, and patient can have low potassium level also. So first of all, if patient is having low potassium level and you are giving insulin, then we will worsen the case. So first of all, we will check the potassium level. So before going ahead, I will give you normal range of potassium. Normal range of potassium is 3.5 to 5.2 milli equivalent per liter. Okay, so we will check potassium level. This is our second step in the treatment. Potassium results are mostly available in half an hour, so it will be easy to check potassium level. So we can get potassium result in, we can divide it result of potassium level into 2 to 3 steps. So first, that our potassium level is below 3.2. Our ideal is 3.5 to 5.2. Second, that it is 3.4. Fourth, that it is 3.5 to 5.2. It is normal. And final, it is our 5.2. So before above 5.2, sorry. So now we will decide that whether we have to give potassium or insulin. So insulin has to be given or not, and potassium will be given as the KCL injection. But KCL has to be given or not. So you note that in our first patient, this is our first patient, this is our second patient, this is our third patient, and this is our fourth patient. In our first patient, the potassium level is below normal and 0.2% below the normal range, normal lower limit. So what will we do? We will never ever give insulin, because it will further reduce the potassium level. So first of all, we will give potassium. What will be the dose? 40 to 80 milli equivalent per hour. Okay, now our second result, potassium level is 3.4. So what should we do? Should we start insulin? Of course, because potassium level has come very nearer to its normal range. So what will we do? We will start insulin, but we will continue the dose of KCL 30 to 80 milli equivalent per hour, because as soon as we start insulin, the potassium level will start to fall down due to insulin. If we to compensate it, we will give potassium injection, KCL injection. Now our potassium level in patient 3 is normal, in the normal range, because 3.5 to 5.2 is the normal range of potassium. So assume that patient is having normal potassium. So what we will start? Of course, we will give insulin, because insulin is the treatment of the diabetic-keto-acidosis. Okay, but as soon as we give insulin, the side effect or action, it will reduce the level of the potassium. So we will give potassium, we will give KCL injection, but here the dose will be different. Here we are giving 40 to 80 milli equivalent per hour. Here we will give only 10 milli equivalent per hour, because potassium level are in the normal range. Okay, and we will regularly measure the potassium level, and accordingly we will give insulin. Now assume that potassium level is above 5.2. Patient has not suffered so much kind of vomiting, dehydration, so potassium level will be high in the blood. So what will we do? We don't need to give potassium, no need to give potassium, because potassium level in the blood is already high, and we have to give insulin, because insulin is our treatment. So in all second, third, fourth patient we will give insulin, because here cutoff is Here cutoff is 3.3. If insulin is below 3, if potassium is below 3.3, first you have to maintain the potassium level. First you have to correct the potassium level in the blood. After that only you can give insulin. So this is our potassium. So cutoff of potassium is 3.3. cutoff 3.3 milliequivalent per liter. It is cutoff. So ये कट ऑफ देखने के बाद आपको ये गाइडलाइन फॉलो करनी है, इंसुलिन कब देना है कब नहीं देना है. अब अगर इंसुलिन देना है, अगर इंसुलिन के लिए हरी टिक है तो कौन से डोज में देना है इंसुलिन को. सो आवर इंसुलिन विल बी स्टार्टेड IV. आई एम गिविंग इंफॉर्मेशन अबाउट द डोज. IV देना है ऑफ कोर्स. IV लोडिंग डोज सबसे पहले देंगे. IV loading dose, we will give it loading dose first. It will be 0.1 unit per kg, followed by we will start infusion. Afterward, first of all, we will give loading dose 0.1 unit per kg, and then we will start infusion at the rate of 0.1 unit per kg per hour. First of all, we will give, for example, I am giving that the weight of the patient is 80 kg. So first of all, we will give the loading dose of the 80 multiplied by 0.1, 8 unit. First of all, we will give 8 unit of insulin by IV, directly IV, and then we will start infusion at 8 unit per hour till the glucose level comes below 200. So here we have to remember this is cutoff 200. Then you have to continue the IV fluid and insulin till we achieve the glucose level below 200. And second cutoff is 3.3. If the potassium level are below 3.3, we will never start insulin. We will never ever start insulin. Okay. So this is the treatment guideline of diabetic ketoacidosis. But sometimes in a rural hospital or this blood report of the potassium will be available after a few minutes. If you need to know the potassium level within a minute or within a 2 minute, without blood examination will give you report after half an hour or 1 hour, and sometimes it may not be available in rural areas, etc. So how will you decide whether as a doctor you should give insulin or not? So we will do ECG. Normal ECG is available in most of the hospital, and it will give a result in 1 to 2 minutes. We will perform ECG, and ECG we can divide ECG finding into two. If we find tall T wave, absent P wave, and broad QRS, then the patient is having hyperglycaemia. So we can give insulin. Insulin is green line. Okay, insulin should be started because patient is having hyperglycaemia. So no worry about insulin, no worry about potassium. But if the patient is coming with, in the ECG there are T waves are absent T waves and U wave present, then it is the suggestive of the hypokalemia. And if the patient is suffering from hypokalemia, we will not give insulin till we maintain the hypokalemia. First of all, we will manage the hypokalemia and then we will start insulin. So this is for emergency kind of thing. ECG is ideally it is best to believe or to take ideally it is best to do blood test. But if blood tests are not available, or if blood tests are having some time and you need to start insulin or potassium, whatever is needed immediately, so you can believe on ECG findings, but ideal is blood test. So it was all about the it was all about the diabetic ketoacidosis according due to hyperinsulinemia or deficiency of insulin.